This conference will now be recorded.
Okay, the meeting has begun. If you want to call the meeting to order, Ms. Montgomery, I'd be happy to take the roll.
Thank you very much. It's so nice to see you all again. And I think we have everyone that we need to have here for a quorum. Benton, would you mind calling the roll?
Ms. Montgomery,
Yes.
Mr. Giacalone,
Here.
Dr. Schottenstein,
Here.
Dr. Cacarala.
Here.
That is, all the members are present, Ms. Montgomery.
Thank you so much. You remember last meeting, we were cut off because of some difficulties with the technology. So just to briefly review you, last meeting, we were worried about the two-tier system that we were talking about, the 72-hour outpatient, inpatient thing, and then also the MAAC letter. I think, had come to a conclusion about the two tiers, but Benton, you'll have to remind me, I was checking our minutes, if the full board has voted on that yet, or do we have to make a recommendation in the board meeting for that?
I will take a look at the minutes briefly. I'm not recalling just off the top of my head.
I couldn't find it.
Yeah, I believe we are going to talk about that with the rule review. So I think we decided to bring that back. I think there was a little bit of a confusion, and we decided to bring that back. So that is on our agenda today, to talk about the changes to the rules that would adjust those systems.
Thank you, Ms. Anderson. With the technology glitch that cut us off right in the middle, even our minutes have to be incomplete. So what we're left with today is to talk about our MAC letter. And we had, as you recall, some robust conversations about the way the questions were asked and the quality of the questions. We're working toward simplicity in the questions and fairness in the questions. And that brings us to our number one item, which is a public records language. In the course of the last meeting, we discussed why not just see if there's a way to, instead of worrying about, obviously we want to worry about the quality of the questions, but in order to ensure that we have better participation, not to hide, but to have better participation and more honest responses to some of these mental health questions, our suggestion was, look, for those questions and answers, to exempt them from public records law. And that would permit the respondents, the licensee or the license applicant to answer more fully, more honestly, and perhaps encourage a better answer. At the time, what we're trying to do is protect the public. In that regard, Ms. Anderson has proposed some language, and I'm going to ask Ms. Anderson to talk about that. You have that in your packet.
Thank you, Ms. Montgomery. So we did talk about developing an exception in the public records law. You can see there are a number of exceptions to the public records law. And so this would be proposed as one of them. It has to go to the legislature to approve this language. This is my first draft. The language, which is that responses to the state medical board license application questions regarding medical conditions that impair ability to practice, and any documentation provided as part of those application questions would be exempted from the public records law. As you know, we receive multiple public records requests every day for license application information. So we're giving those license applications out to all kinds of requesters. This would make the responses to the questions related to medical conditions, which includes physical and mental conditions, redacted from that information that we would give out. The information would still be available for the board to use, but it just would not be part of public records that we send out. And we had an internal discussion about, should we say affirmative responses, so those yes answers, or should we just say all responses? And we decided to propose all responses, because if we're only giving out the no answers, then people would know that those were yes. And I think this is, our first crack at the language, and, we're obviously, at the very beginning of a long process, and would appreciate any feedback from the committee.
And I've given Ms. Anderson some language proposals. Are there any? Does the committee have any concerns, or anyone else? Mr. Jackalone.
Yeah, thanks, Betty. Can I just ask some clarifying questions? The way the language is written here, does that also apply to alcohol or substance abuse?
It doesn't. So
I want to make sure we're talking about
at
the
least
same.
I was not intending that it did.
I don't support that either. That I think is out of scope, but I just wanted to make sure that wasn't. Other question is, when you talk about physical and mental conditions, let me ask you, sexual deviant, does that fall under a mental condition? Is that something we want to exclude?
Yeah, that's a good question. There are 3 conditions that we ask about in our application that are not covered under the ADA: pedophilia, exhibitionism, and voyeurism. And we do ask specifically about those. We also refer to conditions as medical conditions. We don't split out physical and mental health issues. But I think that's a good point. We may want to be more clear that we are not including those voyeurism, pedophilia questions, and we're not including chemical dependency.
Okay.
And I asked this earlier the week with Kim, and Dr. Schottenstein, you'll appreciate this, for the public to know that a psychiatric condition is considered a medical condition for purposes of the language that we're suggesting. So, any other conversation about this as Ms. Anderson goes about sort of doing a little more wordsmithing so that we can propose this to the legislature? Any other questions? If
Betty,
not,
yes. One last afterthought. Where does rage and anger management fall in this continuum? Michael?
Dr. Schottenstein.
So I guess, first of all, I really support the thrust of the project. I think that, medical records and medical conditions should be private in terms of, being released to the public. And at the same time, we still get that information to use as we see fit. I think, it was actually about a year ago, I was giving a presentation, and I actually had a licensee raise his hand at the end of the presentation and say, when we send in these applications for our licenses, this information is public about our medical records. And it was not even something that had been on my radar. So it was on the licensee's radar. I suspect it's on the radar of, the licensee population as a whole. And I think that we're right to be respectful of the fact that people want their medical information to be private. And so in that regard, I also would just again point out there's a difference between a diagnosis and behavior. So when we're talking about things like voyeurism and, pedophilia and, exhibitionism and things like that, we're by and large talking about behavior. When we're talking about, chemical dependency, we're concerned about, impairment in that regard. I think that it doesn't have to be, how shall I say? I think we just want language that moves us in the right direction. And I think if we feel like information about chemical dependency and information about sexual acting out is something that we would still want to be available to the public, I think we're allowed to make that distinction, but still move us generally in the direction of privacy of the licensee.
And I have to say that the public policy people are not, I think quite rightly would say, when you come to behaviors that become, or when we're talking about behaviors which have, the public is not going to, nor are the policymakers going to say a pedophilia, somebody who has been diagnosed as being if he's involved in pedophilia, the public needs to know. And this is not a condition that will be covered and dismissed and not being able for the public to see. And see this is early morning. I'm not saying that clearly, but that will not be exempt from public records request. And there are some public policy decisions that are not going to allow this language, this kind of exemption from public records, and that's going to be one of them. The policymakers may say, "I understand that if he's being treated for depression, we'll keep it private," but I don't think the policymakers will ever buy if we've got somebody who's acting out as guilty of pedophilia. Period. Yeah.
Yeah. So to your point, I think probably in some way, when people answer affirmatively to questions like that, it's essentially going to be a non-starter, practically speaking, for the license anyway. I guess what I'm thinking about as we're talking is, the gist of a previous comment that was made, which is part of the reason for our embarking on trying to get this language approved is that people should feel comfortable releasing the information. And I guess I'm sitting here thinking about the chemical dependency question, right? Which is, if we exclude chemical dependency, does that put us right back in the same boat where people are not going to be forthcoming because they don't want their records released to the public? And again, with the understanding that there's a difference between diagnosis and behavior. And so the question is, we have other questions on the application that have to do with whether or not there is any kind of current impairment going on. And of course, the language right now, even I think goes back to the last 5 years, and we had a recent discussion about that. So again, I guess I question, even though I think the board has the right to draw the line where it sees fit, I guess the question is, should we just sort of leave the language as is, or are we right to start making exceptions?
What language are you referring to?
Forgive me, the language in the proposed statute before us.
The proposed language as is.
Yes, thank you. Sorry.
Yeah.
Yes.
Yeah. Mr. Jackalow.
Yeah, I guess my one comment on this is, there's certain professions that are held to a higher standard, rightfully or wrongfully. Physicians being one of them, attorneys, not comparing the two, but I mean another, right? Because you're dealing with people and their lives and the impact that you have on their lives. And honestly, and I've done this myself. I mean, if I'm looking at an attorney or physician, I will look at their background and I'll want to know if they had a substance abuse issue or they had some other kind of issue, because that is going to be a factor in my decision because it matters to me and it matters to my family. So I'm sorry, to put this behind the veil of privacy. Look, if you're an auto mechanic, no offense, I really don't care so much. If you have a substance abuse problem, I probably should, but I don't. But when you're treating with something that's life-threatening, life-saving to a person, I think you fall in a completely different box, and I think you should have a higher level of scrutiny. I don't think you get the pass. I'm sorry. You chose the profession. You chose it with the positives and the negatives.
Dr. Feibel. Can't hear you, Dr. Feibel.
No, I was looking for my unmute. Sorry. I in theory agree with Bob, Mr. Jackalow, but I just think it's more important to me for the board to have that information than for a licensee to not be truthful about it. And you know, we did go into this profession, but we still deserve, and believe me, everyone on this board knows I am all about protecting the public. But we went into this profession, and it sounds to me like a patient that said to me, well, when I said, well, I'm not on call this week, I wasn't on call, that's why I didn't respond to you. They said, well, you chose this profession, you should be on call all the time. And, you know, yes, we chose this profession. It doesn't mean that we should have, I mean, I'm sorry, substance abuse disorder is a mental illness, and it doesn't mean we should have our medical records dragged through a public records request. I think the board should have access to it. I think the board should be, if we feel it's a big enough problem, then we shouldn't be letting that person practice. I just think it's more important for the board to have the information. So I'm supportive of Michael's position on this, and I think that would be the right way to fall on this.
So may I suggest, since we have a very limited time here, that we continue to wordsmith this for our next committee with an intention to be able to have some language prepared that we can take to the board. Stephanie or Chelsea, one of you, we want to put this together as a package. So what is our timing on this in terms of a package to get some legislation passed?
I think this is fine for us to bring back to you in May, no problem at all. Our idea would be to put this in the package of legislation that's part of the Strauss package. And that right now is going through stakeholders. I don't think that any of the stakeholders we're working through would object on this. I don't feel the need to shop it the same way. This is purely this is really a board operations question in my mind. I think that we can put this in that package.
Okay, so what we'll do is we'll continue to wordsmith. Appreciate the comments.
But I have one more super quick question. Does the one bite affect this or not? Because how does one answer? I've never thought about this, but how does one answer on that application when they're in the one bite program, and how would that all affect? And that needs to come into this too. I don't know how it affects, but just
there's specific language that allows you to not answer that in the questions. There's specific substance use disorder questions, and it talks about if you are in this category, you don't have to answer yes.
If I may just make a real quick comment, which is I'm actually just in support of the language the way it is. And the reason why, as I sort of sit here and think it through more with the benefit of this discussion, is because, you know, when we make an exception, we increase the likelihood, I think, that a licensee withholds information. And so I think when we don't have an exception, we increase the likelihood that the licensee is forthcoming. And again, it's still information that we will have as a board. That was just my only other comment. Thank you.
Thank you very much, Dr. Schottenstein. With that, then, I think our decision is to consider do some more wordsmithing with the attempt to present our final wordsmithing to the committee next time and present it to the board next board meeting for inclusion in a legislative package. Again, underscoring the fact that this, by exempting it from public records, is an attempt for more openness in an ironic kind of way than closure. We're trying to protect the public by making certain we get a better answers up front before we make decisions about licensure. We'll go on to rule review if you don't mind. There are some suggested changes. Obviously, we've just talked about one of them, and we also talked at the last board meeting, at the last committee meeting before we were cut off, discussions about the 72-hour versus outpatient and changing that process and the cost therefore for licensees, both tier 1 and tier 2, as we discussed it. So Ms. Anderson, I think there are some conversations that have been ongoing with OPHP, and I think we have some proposed language changes to make it more conforming with current practice, which is always good. The practice should conform with the rule.
Right.
Go ahead, Ms. Anderson.
Right. Thank you. So we had talked about this a bit at the board, and I think there was some confusion So we did take another look at this. I did work with Kelly Long of OPHP, and the changes that she has suggested to Rule 4731-1605 are set forth below. It updates some language about using a biopsychosocial assessment instead of history, adding hair testing to the urine and blood testing, and then clarifying that for our individuals who get an outpatient assessment, which would be massage therapists, dietitians, respiratory care professionals, radiologist assistants, and genetic counselors, that they would only have a mental health evaluation as part of their assessment if it was specifically needed from the board or the treatment provider if they're coming for one bite. The other thing, so we've got 3 rules that are impacted here that we're proposing to make changes to. And what we want to end up with is the individuals that I listed off would get outpatient assessment, and they would get outpatient treatment if they're ordered by the board. And if they're in one bite, the one bite treatment provider will determine their treatment that is necessary. And I think under our rule, if the treatment provider should determine after they do the outpatient treatment that they need more, that's something that's available to the treatment provider. But we want to match it up so that these additional license types look like how it looks for a massage therapist now. So they have an outpatient evaluation and they have outpatient treatment. And then it gets a little confusing because one bite borrows from that 1605 rule for their evaluation requirements, but they don't for the treatment requirements. They have their own standard for that. So I think that's where we were having some confusion. But I think the edits that we have now make it match up so that for those individuals in that group, they would look like how massage therapists look now for their evaluation and treatment. And I think that will provide a lot more flexibility for OPHP for the one bite individuals too, to have an outpatient evaluation. So that what I'm proposing is that we would send these rules out with these edits for initial review. We'd ask the board to do that this afternoon, and then we could get comments back as well.
Dr. Schuttenstein.
Hi, thank you so much. So if I may clarify one point, and you already sort of touched on it, I think, if, let's say, hypothetically, a massage therapist has a chemical dependency assessment, and the person doing the assessment feels the massage therapist needs a higher level of care than intensive outpatient, is that something that can be recommended?
I think that happens after they do it.
After they do what?
The treatment, the outpatient treatment.
So that was sort of my sense as well when I was looking at the language, but I just sort of wanted to double check. It sort of looks like they are on the road to that, but then potentially after there can be additional recommendation.
Mm-hmm.
Is that right?
Yes.
Okay. And then if you'd be so kind, I did just sort of want to touch on 1605 for just a moment. So when we replace psychiatric evaluation with mental health evaluation, what does that gain us? In other words, what's the benefit to changing the rule that way?
That was the recommendation from OPHP that the idea behind that is that was the more accepted language, that was the more updated language. It probably allows for additional practitioners.
That's what I'm guessing too.
That-
So I just sort of wanted to make that
Sorry,
clear. And
it probably
it'll allow-
allows for what?
It probably allows for additional practitioners, which might include psychologists or counselors.
Right. And fair enough. But I just sort of wanted to make that point as well. That was sort of how I understood it as well, which is you're going to have a wider variety of professional, essentially, that are going to be able to do these evaluations. And then one line down where comprehensive biopsychosocial assessment replaces chemical use history. You know, a biopsychosocial assessment, I mean, by all means, I'm glad to have a comprehensive biopsychosocial assessment, but essentially it's redundant with a mental health evaluation. It's basically the same thing. In fact, a biopsychosocial assessment includes the mental health and the chemical use history, right? So, you know, a biopsychosocial assessment is not redundant with chemical use history. It encompasses it. So, in fact, you could actually just have one line that says comprehensive biopsychosocial, assessment, except as in paragraph A3B2, and just leave it at that. Instead of having those two lines, that is actually a little bit, redundant to have those two lines like that. Do you follow me?
Yes, thank you.
Yeah, of course. So, depending on your comfort level, I would probably change it to make it more clear.
You would delete what is now A1 little or A2 little c and just use A2 little d comprehensive biopsychosocial assessment except as in paragraph A3B2.
Yep.
I tell you what, why don't we use, we're running a little bit out of overtime. You could do the wordsmithing. The only concern I would have is the language. If that's a language of art, I understand. Otherwise, it seems a little fancier than just calling it a mental health whatever. So I'm speaking as a non-doctor. But
well, so the interesting thing is before the rule made a distinction between mental health evaluation and chemical use history, right? So those are in each line. So if you're going to keep mental health evaluation, then it kind of makes sense to me to keep the next line, specify the chemical use. If you say biopsychosocial assessment, you're sort of including everything. If you wanted for emphasis to say including chemical use history, you certainly can. But really, a biopsychosocial assessment should include all of those things.
Okay.
So, I think we're running out of time. So let me just say to you, look, we can wordsmith this. It seems to be the way it stands without changing that language and just leaving it chemical dependence and mental health. You've got it clear, and you're not using the fancy language, but it's clear. And why not just leave it in place instead of looking like we're grabbing for every time there's a new fancy word. If this works, why not leave it? Anyway, I would suggest that we work on that and you can bring it back to us. We don't have to approve. We have to make, well, what we do, we've had discussion. Can we approve it?
I can bring it back to you next month. That's fine. I would this is raising some other questions for me that I'd like to talk with Dr. Schottenstein about to make sure that we have all the components of the evaluation that we should have. So could I just bring it back to you?
If that's the will of the committee, I think we should do that. But can I just admonish, or for those of us who are not in the profession, if we don't have to keep chasing after the most updated fancy language, unless that's really important. I think simplicity is really important. So with that in mind, why don't we wait till if the committee permits, move this on till next time and let Miss Anderson take a look at it.
Okay, great. And my concern is, these are suggestions from OPHP.
But
So
we
I
are,
want to make sure that we're harmonized in what the expectations of the elements of the
Right.
evaluation are.
right, but we still remain the board, and I agree with alignment, but at some point we are the board, and we will do what the board feels is appropriate with appropriate collaboration. We move on to the treatment provider applications. I'm sorry to move things along so quickly, but we lost 10 minutes, so we don't have, Brandy, Dorsey is, she was cut off last time, and it looks like at the end of the committee meeting, she's going to be cut off again. We have two treatment providers, one Lakeview Health Systems that appears to meet the criteria for a treatment provider, and Tri-Health Bethesda Alcohol Drug Treatment, again, appears to meet the criteria for approval as one bite continuing care treatment provider. Ms. Dorsey, do you have any comments or that you'd like to illuminate us on?
No, nothing more than what's outlined in the memo. They're both utilized providers, and Tri-Health is an outpatient continuing care provider that has been board approved before. They need that to be updated, and then they also would like to work as a continuing care provider with the One Bite program.
And I assume that continuing care provider is a word of art versus just a treatment provider. Or you've got a one bite provider, you've got a continuing care treatment provider, and you appear to have different level of provider that we have to approve. I'm just asking the question.
Right. They have to be, their board approval needs to be updated, and then they are requesting to be a One Bite continuing care provider. So it's a specific they want to do the outpatient continuing care. They're not applying to do the inpatient One Bite treatment.
Okay. Are there any concerns or comments regarding these recommendations that we recommend these two health systems for approval as providers? If there are no, then do we need to take any kind of action, or can we just do we need a motion, Benton?
Yes, if we can make a motion to recommend to the full board to accept applications, that would be great.
All right. We have a
So
motion.
moved.
Dr. Caparella moves, and is there a second?
Second.
Dr. Schottenstein seconds. It's been moved and seconded that these two providers be recommended to the board to become licensed treatment providers, the appropriate licensed treatment providers. All those in favor?
Aye.
Opposed, same sign. All right, we're going to make those recommendations at the board meeting. Brandy, I know we're running, we have just a few minutes. Are there some statistics you want to tell us about? I can't see you if you're on. Oh, there you are.
Oh, you see me? Okay. Nothing major to report from the statistics. They're pretty explanatory. Essentially, what I want you all to know is that we are continuing to provide these to you monthly, just for you to know what's going on in the compliance department, as well as for me to take a look at these from a program perspective overall and figure out what changes we need to make. We're going to be revising the guidelines that we utilize and make some proposed changes in the guidelines for supervision, which is going to include making sure that we have appropriate staffing to supervise the licensees who are under our purview, who may have a lot of red flags, and being able to really focus on those individuals. So we feel like the statistics that we've been gathering on a regular basis regarding the type of complaints that are coming out of compliance and tracking those and seeing, where things are moving will help us to give a program overview as a whole so we can make any changes.
Well, thank you, Ms. Dorsey. We've gone through, I know that I think that the most significant thing you've talked about in your statistics or in your comments is that as you start to narrow this down, you're going to look at the priority and the red flags as our first role in compliance committee to look at is not just a wealth of data, but the data that is focused on where we could have problems and alert us to where we can better protect the public. That's correct.
Absolutely. Yes.
All right. Well, thank you so much for your hard work, Randy. And again, committee, I'm very sorry that I pushed this a little bit, but we are running over into the FSMB committee now. So my apologies. With this, I think we shall adjourn, absent any other conversation or communication. All right. Thank you so much. We'll see you at the 9 o'clock FSMB recommendations committee.
Thank you all.
Thank you.
Thank you.